excellent presentation about the genesis of the disease of orbitopathy and discussing teprotumumab as a therapy for this management. We can allow a few minutes for questions from the audience or from the online audience. Dr. Ali is with us also here. So please, I cannot see the audience in the room, but if there is anybody who wants to go and walk up to the microphone and ask a question, please do so. Until we can maybe get one question. Dr. Ali, with us? Yeah. So a couple of questions I do have them. One of them is related to what would be the best time to start teprotumumab in patients with mild to moderate disease. Now, we mentioned that the enrollment of these trials and the phase 1 or 2 were usually on an average of 9 months, but would you start them like right away after diagnosis and presentation of the visual symptoms, or would you allow the antithyroid medications if they would do any difference in the outcome of the eye disease?
So in general, antithyroid medications do not significantly alter the disease activity. You may get actually some improvement in the lid lag and lid retraction, but it usually doesn't affect the course of the disease. So to answer your question directly, yes, I think those patients should be started as soon as possible, provided they have active disease, the clinical activity score more than 4, as it is the case in OPTIC and OPTIC extended trial. The golden period is the early intervention, and the early intervention is with that graph that showed the acute phase usually within the first 9 months, but the earlier the better. Now, I think the new thing here is, what about if a patient has a long-standing disease, but he has an active disease? Phase 4 trial suggests that those patients actually improve. And I think there is always a window of opportunity to start this drug or any other treatment for patients with an active disease.
Thank you, Dr. Ali. We can wait if they can tell us if in the room there's any questions. I do have also like maybe a couple. Is there any molecular monitoring? Is there a molecule that we can monitor to see the activity, or is it just a clinical evaluation based on examination?
Although there is some correlation between the TRAB or the TSH receptor antibody and the activity of the disease, it is not clinically useful. So still the monitoring depends to a great extent on clinical activity score and the clinical evaluation.
We have a question, right? Yeah, go ahead.
A very nice presentation, Dr. Ali. Just a quick question, and I think a couple of people in the audience also had this question, was in general about the cost as well as the availability, especially in the Arab world. And the second is, who actually does the infusion? Obviously, this requires multidisciplinary care. It requires the ophthalmologist and the endocrinologist. But who actually does the infusion? Is that done by endocrinologist ordering it or ophthalmology? And is that ever a problem if they disagree?
Yeah. So the cost, I don't know about the cost. I know it is costly, but I don't have really specific knowledge of how much it costs. I think it was very costly and it has come down significantly. But I think in terms of administration of the drug, I think the best thing when you have a patient with moderate to severe disease is to have a combined multidisciplinary team. Actually, it's always very important to have partner with you as an endocrinologist, an ophthalmologist, an oculoplastic surgeon, and vice versa. If you're an ophthalmologist, to have an endocrinologist on board, because this is the same disease with different manifestations. You need both of them. Now, in our hospital, we have actually daycare or day procedure unit, so we can arrange for it. Patients come to the day procedure unit, get evaluated, make sure that everything is fine, and then they can get started on the infusion. Other places, I think every hospital has its own setup. It is variable, but you need a place where the patient will be evaluated before infusion, get the infusion over 1 hour and monitored for some time. So in some hospital, they admit patients. In other hospital, they have day procedure unit where they can do this. And the drug, again, variably administered by endocrinologists, but more commonly by ophthalmologists. So it all depends on the institutional setup.
We have one more question from audience. We cannot hear the sound, so.
On whom we started the medication, and they really had to struggle to get because of the cost. Now, the Red Crescent is providing some help if some application is put ahead of time. But it would be nice for the company to guide the patient, because knowing the effect of the medication and seeing patients with significant proptosis and the result that we get, I think it will be very helpful from that perspective.
Thank you, Dr. Ali.
So since we don't have any more questions, thank you, Dr. Ali, for your presentation. Again, thank you for Amgen for sponsoring, and thank you for the all audience attending. We can conclude this session and then move on to the next one. Thank you, everybody.